So, we've spoken about spinal injuries. We're now going to move on to think about injuries of the other muscles and other bones as well. So we're still going to think about how has the injury happened. So were they thumbing a lift and the person came too close and took their arm with them, so they've broken their arm? Were they fighting off an intruder, lifted their arm up like that, got hit over it and had what we call a watchman's fracture? So in the 18th century, when you'd had watchmen going around, thugs would come and beat them, so your natural reflex is to lift your arm up like that to protect yourself. So we'll break the bone there. So think about how the injury happened. Think about, is there any blood loss associated with that injury? And is that injury compromising the circulation or nerves going beyond that? So I remember going to a car crash a couple of years ago of an 11-year-old who was crossing Edgware Lane and a car came and sideswiped him and didn't do too much to him, except for the fact that it very clearly broke his leg because he couldn't walk. And okay, so he broke his leg, but it looked all right. But his toes were quite white, quite cold, and he said they were very painful. And every time we moved his leg, they would pink up, and when we tried to lay his foot back down, it would go white again. So the break, although it hadn't cut off this, it was compressing the arteries going into his foot, so he wasn't getting circulation. So you need to think about that, because the break, because by the bones you'll have arteries, veins and nerves that are going beyond that. So the break itself might be, while the break itself is fairly straightforward, it might be compressing the thick structures around.
So basically it was tourniqueting.
Yeah, so basically the fracture was tourniqueting the leg beyond the fracture. So it wasn't actually putting it was putting pressure on the arteries and stopping blood flowing through them. Okay. Now we're also going to talk about how do we tell the difference between a strain, a sprain, a fracture, or a dislocation. Okay, so these are all very, very common injuries. We'll think about how we tell the difference between them. We're going to talk about when do we immobilize it, when do we not immobilize it, where do we refer this patient on to, what sort of painkiller might we want to use. Think about using cold compresses to support things, splinting, and how do we control blood loss from these type of injuries. Okay. So, what sort of thing would we want to immobilize and why?
Broken bone, to stop the bones rubbing against each other, or
Okay.
possibly piercing an artery or damaging something
Yeah,
else.
so if something is clearly broken, so you see something that's out of shape to what it should normally be, then absolutely you want to immobilize it because it is a form of painkiller. So broken bones, while the bone itself isn't painful, the periosteum, the layer around the bone, is very, very sensitive and it has lots of nerves in it. So that's why broken bones hurt so much. So fixing it in place is going to be a form of painkiller. Okay? You're absolutely right. We want to make sure that it's not going to cut a blood supply because there's blood vessels running next to the bones. We want to make sure it's not going to cut them. We want to make sure that the sharp ends of broken bone don't pierce into them and cause bleeding and injury like that. Okay? What if it doesn't look like it's particularly deformed? If it looks all normal, but it's still very painful?
It doesn't mean it's not broken.
It doesn't mean it's not broken, you're right. It still could be broken and you'd still think about immobilizing it. How might we, though, be able to tell if something is broken or not?
It's out of shape.
So if it's obviously out of shape, but if it's not out of shape, what sort of
pain?
By the movement.
So pain, so they're all going to be painful, and so they all might be swollen. But you're right, movement is really important because a broken bone can't move because it loses the mechanical advantage that the muscles are working on.
Also, if it's a single bone
Of the arm, yes,
Yeah.
because you lose the mechanical advantage that the bone is of the bone, so you won't be able to have
if
more
it's
movement.
attached, there is, I remember, maybe it was a broken bone, that's still in the same shape.
So it might not be painful at that point, but if it's very stable, then you might still have some function, but the movement, if it's broken, you tend to lose movement at that point, because the bones have to, to have movement, the bones have to move position, and if they're broken, they lose that mechanical advantage of where they are. So they probably will lose movement. Okay. And some of the things that we use.
Blood swelling as well. Swelling.
So swelling will happen both in a broken bone, or it can also happen in a sprain, or it can happen in or a strain. It can even happen if you've torn a muscle or something. Anything that will cause blood or fluid to collect there will cause swelling. So swelling isn't a good indicator.
That's interesting about the movement side of things. So
Yeah.
He's 9 at the moment, so 4 years ago, COVID, he found a quicker way down to the bottom of the slide.
Yeah.
Jumped up crying, and was going like this. Sat on the bench, not the first kid, so
Yeah.
he couldn't have broken it because he was going like this with it. But yeah, he had a green stick fracture.
Yeah.
But even in the palm, for example, they have like multiple bones,
So if they're very stable, then you might still have movement. Green stick fractures are where just one side of the bone is broken and the other side hasn't, so you might still have movement in it. I saw quite a spectacular green stick fracture when I was in A&E of a not your son because it was a little girl, but she also made a slightly quicker descent from the top of the slide than intended. And she then put a coat on in nursery when she was being picked up by her mum 45 minutes later. And when mum came home and took the coat off, mum fainted. And then when she woke up, she felt really sick because the arm was pointing at about 70 degrees out of where it should be.
And the kid wasn't crying?
The kid was not crying, but when we did an x-ray she had a lovely green stick fracture of both the radius and the ulna,
Yeah.
which was quite obvious from when looking at her, but because it was a green stick fracture it was still quite stable, so it wasn't so painful.
Did your mum have any injuries?
The mum didn't have any injuries,
what's
fortunately.
the meaning of a green stick? It's like a green stick that
So you know how a green a branch,
Living
which is
branch.
a living branch, when you break it, it doesn't snap, but it cracks along. It cracks along the top side,
Like stringy cheese.
and then the bottom compresses, and it's really hard to break because of that. So that's exactly what happens. So children have soft bones. So when the force applies, so
Yeah, not going to work that way.
Yeah. okay. So you see, so that's what we call a green stick, where because you've got compressive forces occurring on one side of the bone, and you have distracting forces on the other side. So the distracting side will snap, and the compressive side will compress. Okay, so you only get a break in half of the bone, and on the X-ray you see where it's all compressed down and it's all bunched up. That's a green stick fracture. You don't get it as an adult because the bones are that much harder, so they snap rather than.
And if somebody is very flexible,
That doesn't. It's not to do with flexibility.
it's nothing to
No.
do with flexibility.
Okay, so that's to do with bones. Sprains are where two tendons, so these are the attachments between bones, get pulled. So we've got lots of ligaments in our feet and around various joints. When those get stretched or torn, that's called a sprain. Okay, and they will be very painful. They may or may not be swollen, but the movement is preserved because the bones, because the movement is done between the bones and the muscles, not in the ligaments. Okay.
Like that.
Yeah, that's a green. Yeah. So that the picture that you
see
show.
the half is
So when you look at the X-ray, one half of the bone is broken and the other half isn't. Okay. And then sprains is where the muscle gets injured. So so you get tearing of the muscle fibers. And if it's a complete tear, you might feel it. And I have a patient who has a big dip in their thigh because they were playing football in school. At 65, you should be playing football in school with the children in school, but you're more prone to getting injuries. And he managed to tear one of the 4 muscles in his quads, and he's got a massive dip in his thigh where that muscle is torn. but because the other three are around it and supporting it, he functions and everything is as normal. But in a when you get sprain, when you get a tear in the muscle, that's where you get that. Now initially it might be swollen because of the immediate effect of it, but it might also cause bleeding because of the ruptured blood vessels within it as well. It will be painful, and depends on how much muscle is being torn as to whether or not there will be a loss of function or not. But if it's a complete tear, then what will happen is you'll see the muscle bunching up above it, because muscles can only contract, they can't straighten themselves. So that's why you've got all the muscles in the body working groups. So you have two opposing muscles that allow movement. So when you show off your biceps by doing the biceps curl, that's opposing the triceps, which is the muscle on the back of the arm. So you need the triceps to pull the arm straight to pull open the biceps. And the same thing happens in your thighs. You've got the quads and you've got the glutes, which work opposite each other. And so all muscles have opposite muscles that pull them straight. So if you have a rupture of a muscle, of a tendon, which is the bit that connects the muscle to the bone, then you get the muscle bunching up and you get that loss of function because there's no opposing force to it. Okay? They might not necessarily need demobilizing because once the muscle's bunched up, that's it really. Okay? So which of these would we refer on to a healthcare facility? So a break probably needs to go to A&E. A sprain or strain doesn't necessarily have to go to A&E. They could go to a walk-in centre, or if it's particularly mild, especially nowadays, there might be something that they can go to a physiotherapist directly. They don't even need to go and see a doctor for. If you're not sure though, and the difficulty is that they've called an ambulance and because they're not sure, so the default position will be to take them to A&E, but you might be able to direct them to a walk-in centre if it's just an isolated injury and they're mobile and they're able to get there by themselves.
The trick will be with all is to refer them to somewhere that can X-ray if they think they want to.
Yeah. And for us, so Edgware Walk-in Centre can X-ray, Finchley Memorial can X-ray, Barnet can X-ray. But if you refer them to their GPs, they're going to have to refer them on for an X-ray. It's not going to be so helpful. And I saw someone last week who came in having fallen off, I can't remember what, and they were very painful. But they had good movements. I thought it was more likely to be a sprain, but it didn't quite fit with the pain when I touched it was more than I expected. So I sent them off for an X-ray, and lo and behold, they did break. They did break what I thought they broke. So it can be quite difficult to tell the two apart. So it's about making sure that you send them to somewhere where that option is available. So you're not sending them to one place and then they're having to go to another place afterwards. Okay. What can we do painkillers wise? So we've already spoken about immobilizing things. What else can we use for painkillers? Or analgesia, to use its medical term. Yeah, paracetamol, absolutely. Paracetamol is a brilliant painkiller, much maligned by all the people who use it because they don't use it correctly. But you're right, they don't use enough of it and they don't use it frequently enough. It is one of the safer medications. It's quite hard to do yourself damage with paracetamol, although it's not impossible. And I have a patient who religiously followed the instructions on the paracetamol tablet, taking it every 4 hours. And I said to them, does that mean you took it 6 times in 24 hours? And he said, yes, it says every 4 hours. So every 4 hours on the dot, I took it. And he came to see me 48 hours later. And I said, it says after the take every 4 hours, maximum dose of 8 tablets a day. And he said, and I said, well, I've seen a lot of people who've done that, and they've not come to too much harm, but I sent him off to hospital anyway, and it turns out he was one of the unfortunate people who really do get to harm, and he spent 3 days in hospital being treated for paracetamol poisoning. So it can happen, but if it's used correctly, it's a very effective and very safe painkiller. What other things can we use?
Gas and air.
Gas and air, absolutely. When might we not want to use gas and air?
Oh, for respiratory issues,
Yes. Yeah.
Yeah. So if we think so if we think they might have a gas-contained part in the body, then the problem with gas and air is it will try to go into gas spaces. So if they have a space in the body that's already containing an abnormal amount of gas, giving them gas and air will make that worse. But you're right, it's a very good painkiller. What's the benefits of it?
Non-invasive. From.
It's relatively non-invasive. The patient controls it, though. It requires a patient to take it. It's not something that you can give someone. Paracetamol, you can always get a suppository and shove it up their bum, or you can give it as a drip. It doesn't require the patient to take it. Whereas gas and air, you can't make a patient take it unless they want to, because they have to breathe it in, and it will only work if they are breathing. Okay, so you can give them the gas and air, and they can hold it in their hand, and it won't work because they are not breathing it, and they need to be able to suck it in with quite a reasonable amount of force. So what I say to patients when I give them gas and air is, take this, make a good seal around the mouthpiece, and you suck in like you're sucking in a thick milkshake. So if they're not Jewish, McDonald's. If they're Jewish, a pizzaza milkshake. But you need to have a reasonable amount of force. So very young children or people who have problems with breathing might not be able to use it properly. Okay. What are the advantages of gas and air?
It's out your mind very quickly. Like doesn't have a long lasting effect.
It's got a very quick onset, so you need to take a couple of breaths of it and it starts working, and it's got an even quicker offset. So as soon as they stop breathing it, it stops working.
Which means they need to go to surgery or anything. It doesn't interfere with medication they might be given there or something.
Yeah, it's a very quick on and off thing. Okay. Disadvantages? It's very quick on and off.
Yeah.
So
And require.
It can make you feel nauseous as well.
it can make you feel a bit nauseous. It can make sometimes people feel a bit sick with it.
You can't really do from it. You can't really have too much of it.
You can't, because as soon as you stop breathing it wears off. You do need to be careful with using it for long periods of time, because it can deplete various vitamins in the body, especially vitamin B12, and that can cause damage to the nerves, which is why it has become illegal to sell little containers of nitrous oxide, and you can only now buy the catering size ones, which sort of defeats the purpose of the ban, because before the children were taking the little ones and they were having to buy lots of them, and it was leaving a big mess, but it was much harder to take a lot of it. Now they just buy the big one and they get
That's
all
what
the
gas and air is then.
Yeah.
Not gas.
But now they're selling only CO2. The little one, no?
So the little ones are
You've got the
CO2.
ones for the
Catering.
Yeah.
catering for milkshakes, for cream.
Yeah. But the ones that have laughing gas in them.
Yeah,
So the problem is that they took away the little ones because people were making a mess with it. Now they have the big ones, so they can get B12 deficiencies and a condition called demyelination of the spine.
And drive the M25 with a big balloon.
But those little things, I mean, you've got to have quite a few of them.
You've got to have a lot of them, but the big catering ones, there's enough there to cause people quite nasty injuries.
Is that why recruiting new solo members? Because they've all got using the gas in it?
No. And some people and people can get addicted to it, so it is an addictive.
My wife shouted at the nurse once during labour because they bought her gas in there in a portable tank.
Yeah.
She said, "What am I going to do with that? Why is it not plumbed into the wall?" She thought.
Yeah.
What happens when it runs out?
Get another one.
Yeah.
But
What is addictive about it?
it gives you a euphoric feeling. So it's the euphoria. That
So it's more about, but it's not a physical addiction though, is
It's
it?
physical
Like with
addiction.
codeine.
It's a drug.
It's the same. It's the same
Gets you
sort.
high.
It's the same sort of high that you get with codeine.
So the body relies on it then.
Eventually. Yeah.
Because it's mild, but you have a different impact.
So it's not uncommon for patients with sickle cell to then manage pre-hospital ambulance crews with Ventanox. Particularly, years ago, that used to be the only thing we used to do, and it wasn't uncommon for a large group of those to become addicted to Ventanox. And then they called the ambulance just for that. So then they went through a phase of never getting any, which was bad treatment because we didn't manage their pain. And now generally they're pain plans and you work out what their actual pain strategy is. But it was really common when I first started in ambulance services.
And the problem is that it is such a good painkiller. It is a really good painkiller.
I've tried it in labour wards.
Yeah, so was me.
So
What did you have with your labour pain?
Whenever the nurse went out of the room, it goes away so
There's no point
quickly.
both of you suffering, was there?
It goes away so quickly. You just walk back, you sit down for a minute, you're back to normal again.
Yeah. So when I went to antenatal classes, they at that time they allowed you to try it, but it gives you that, as you say, it gives you that nice feeling, which is the addictive bit about it.
I use this quite a lot to put patellas back in. So your kneecap, when it comes in, it dissipates. Entonox.
Yeah.
They get to a point where you can just pop it back in. Lovely.
Or you do what I do, which is not realise that the patella has been dislocated straight into the leg and it pops back in.
Yeah.
But that's the really painful way of doing it. But because it is such a quick on and off thing, that's why it's so helpful and so useful. And it is a relatively safe medicine.
So do they have it on ambulances?
Yeah. They do have it on, but they only have small cylinders, so you do run out of it.
Yeah, we do run
Yeah.
out. Most ambulances
Is it
carry
both?
two.
Yeah.
So, but
One for
normally
the driver, one for the backup.
yeah.
That's why you join.
For ambulance crews, you'll often start a patient on that, and then they've got a bit of pain relief going in, and then you'll look for a line and give something stronger to last on.
Okay. So it's a useful thing. In little children, don't dismiss the effect of distraction. So blowing up a balloon, a glove into a balloon and tying a knot in it and drawing a face on that can sometimes be a very effective form of pain relief.
I was going to say YouTube, but that might be illegal now.
Yeah.
I'm not sure where the line is actually.
Thomas the
That might be
Tank.
supplying.
The number of patients that I've done stuff to while watching Thomas the Tank Engine.
Yeah.
So distraction is a really useful tool, and it works across the ages. But children are more susceptible to it because they buy into it much better.
That's like more
What?
That's like more therapy.
Yeah, but using that as a form of analgesia is really important. Okay, cold compressors, absolutely, they're very effective for anything that's swollen. So it will reduce that swelling, and it works as a very effective painkiller. Okay.
Do we use those, those poppable cold pack things on the ambulance?
Yeah.
Do we have those ones?
Yeah, we've got them. The problem is that they only last for about 20 minutes, but hopefully you'll be in hospital by then. So, but that cold is a really effective tool. It reduces the swelling, so it reduces direct damage. But remember, it is really cold, so make sure that you're protecting the skin from it. So you don't give the person a cold injury as part of their treatment.
Do you sometimes combine cold with heat with our muscle injuries?
Not in the immediate setting, but longer term, they might use that. They might use heat for especially if the muscles are very tense, to allow the muscles to relax. But then they'll use the cold to reduce any swelling.
I think heat is used by physios further down the line to promote blood flow
Yeah.
to things like ligaments and tendons to then have good ones.
Yeah. Okay. So it's more the heat more is for more stiffness and things. Okay. Splinting. You can never go wrong with splinting because number one, it treats fractures, it keeps them stable, and number two, it's a very effective way of painkillers. Splinting doesn't necessarily though mean taking a box splint and putting it into splint. It might be taking two fingers and taping them together. That's already enough of a splint. It might be that you take something and put it against it. So in the ambulance we've got the sand splints, which is basically an aluminium sheet covered by foam, which you can mould into the shape that you want, and it gives you a bit of stability, and you can fold it into different shapes to give it more rigidity or make it a bit more flexible to fit around whatever you're trying to fit it around. Okay.
What's the name of it again?
Sand splint.
So,
We'll show you.
Use of which part of the body?
You can use it anywhere really.
Yeah, you just have to get bigger.
You just need to make sure that it fits properly. The extreme end of the splints are the spine boards, which is a splint that you're using to keep the entire person still, all the way down to the small, which is taping two fingers together, buddy splinting them basically, which requires a piece of tape.
So for expedition medicine, it's often taught to carry sound splits because they roll up really well and they're quite versatile.
Yeah.
And we teach people how to make collars out of them. So you can use them for quite a lot of stuff.
And they're very good, and they don't weigh much either, which is really important because you have to carry all this stuff with you. It's quite a bit to carry. Okay. Does that all make sense about musculoskeletal injuries? Does anybody have any questions about that?
You're going to use stronger meds like morphine.
Yes, absolutely. Do you have a home office license or paramedic?
So morphine is covered Schedule 17 and 19.
Yeah.
So morphine's covered in ambulance services. I'm a prescriber, so I carry morphine, ketamine, Penthrox, Entonox,
You're good to be on a
paracetamol, ibuprofen. Yeah. So I can go from
fentanyl.
take a couple of fentanyl.
Fentanyl is a
is
stronger form
So fentanyl, the law in the UK has just changed, so paramedics couldn't use fentanyl at all. It's just changed and we can. They're just working out where it sits in the legislation.
Yeah.
So,
and I just have a home office license, which I don't need to pay for because it's a personal license, and I can carry anything. So I carry morphine and diazepam because I don't want to carry more than that.
so as a prescriber, I can prescribe more than most people,
Yeah.
but there's limits to what a paramedic can prescribe over a doctor.
Yeah, I could prescribe anything.
Yeah.
So I could carry it.
Goes to this law.
It's just I'm a bit nasty to my patients and I would give them an offer of morphine or that's it.
Well, I mean, I've also got propofol, Rocuradin and stuff, but they have to.
But that's not a painkiller.
No, it's not. They won't feel the pain, but
Is
for a
cocaine
different
a
reason.
painkiller?
What?
Cocaine.
Yeah.
yeah. So yeah.
Is that used?
Yeah, they used to.
Yes, it's called diamorphine.
They
That's
use it
the
for.
It's exactly yes. So diamorphine
Dentists
is
use it.
Yeah.
diamorphine is heroin and cocaine is morphine.
So they use it for chemotherapy.
And they use it
patients
for chemotherapy.
Yeah,
going
opium.
to malfunction.
I thought opium that was opium is heroin
Yeah.
Yeah.
Comes
So that's diamorphine.
and cocaine
So-
is
Comes from the poppy plant.
Yeah.
the same thing. Cocaine and heroin
Yeah,
and
cocaine.
opium is all the same thing.
All the same family.
Both same family.
The only difference between heroin and diamorphine is one is made in some shed somewhere and one is made in a sterile environment by a company that charges far less money for it.
Yes.
Yeah.
But you can get far less of it. So.
What? No. So diamorphine is made by a company legally, and you need a prescription for it, and it costs about £1.50 a vial. Whereas the heroin is made by some dodgy character on the corner somewhere, and you don't know what you're getting in it, and they'll charge you £2,500 for the same amount.
But morphine like puts you to sleep.
Yes.
Cocaine makes people jump around.
Because that's how it's working in the brain. The bits of the brain it's working on cause that. And that's why if you give someone too much of these medications, it suppresses their breathing. That's where it's working in the brain.
Depending on the drug, some analgesics are dose dependent, for the effect. So something like ketamine, you have analgesic doses, and that just takes the pain away.
And then
You have sedative doses, which means then asleep for a little bit. And you have what we call induction doses, what you give them before you put them to sleep properly. So same drug, it's just the dose you use and the speed you use it changes the effect.
Yeah. And the same thing will happen with morphine. So when I was doing retrieval work with the Berlin Children's Hospital, we would just carry morphine in the back of the ambulance, and you just gave the children that you're taking ever increasing amounts of morphine.
And the risk is they become addictive.
Well, when you're using it for short periods of time, that's not such a risk. And at the end of the day, it's not dangerous to stop. So even if someone does become addicted to it, medically it's quite easy to get them off it. They won't thank you for that, but it's not hard to stop.
But heroin's very hard to stop.
That's the same. It's
Is it?
easy. It's easy to stop, but it's hard. It's harder because of the psychological effect.
I'd say the difference between heroin and morphine in that respect is the reason why it's being taken, right?
Yeah.
So the morphine is being taken because something acute has happened and you're in pain and you get out of pain. Heroin is being taken for an entire lifestyle, different thing, mental health, all that kind of stuff. So the reasons to keep taking the heroin are still there, the reasons to keep taking the morphine aren't. once you treat it, right?
Yeah.
So then that addiction thing isn't there because the drive
Visa
for
is
taking
not there.
it isn't.
Yeah.
So would you give Subutex to somebody who's got addicted to morphine or to heroin, the same sort of drug?
It will have the same effect, but at the same time, if someone gets addicted to morphine because they've had chronic intractable pain, in theory it's much easier to treat because you can just stop it. They won't thank you because their problems will come back, but the psychological pressure to use it isn't there, as opposed to when you use it as heroin or cocaine, where it's a lifestyle psychological drive.
I thought it was a physical addiction that people.
You do get physically addicted.
Withdrawal
But-
symptoms.
Yeah, the withdrawal symptoms.
Yes,
yeah.
and the withdrawal is what you get with a physical addiction, but they're not dangerous to stop. There are medicines that are physically dangerous to stop,
That's what I was
which
gonna
is
say.
which is different. So
Like
things
what?
like the benzodiazepines, so midazolam, diazepam. When people get addicted to those, it is dangerous to stop them because they can have seizures when they stop them. Or someone who's addicted to alcohol.
So alcohol is a problem.
Yeah, alcohol is someone who's addicted to alcohol. Actually, they mustn't stop it. So if you have an alcoholic who has decided to suddenly stop taking alcohol, and plenty of alcoholics do this because they're very conscious of the damage it does to them, and they're drinking 3 bottles of vodka a day, and they say, no, this is causing me lots of damage. I can see I've put on loads of weight and it looks sallow. I'm going to stop it. They stop it because they've got the willpower to stop it, and then 3 days later they hit the withdrawal and they get really unwell with it.
And then they have seizures, and
they have
seizures
seizures.
when you turn up after they've had a seizure. That's what.
So slowly, basically.
Yeah. So or there are medicines that can be used to combat that, but it needs to be done safely. It's not someone has been drinking 3 bottles of vodka a day for the last 10 years and they can just decide, okay, I'm going to stop today. That's actually quite dangerous. Although they might be drinking that alcohol because alcohol is a very effective painkiller. And you will get to see lots and lots of people who, while they're intoxicated, get massive injuries and they don't feel them because the alcohol is working as a painkiller at that point in time.
Understand.
So quite commonly on program we'll see people have really nasty injuries and they can't feel them because they've got enough alcohol on board to sort out the pain at that point in time.
So just to go back to the question.
That doesn't mean that everybody who's in pain gets a shot of whiskey.
Yeah.
I thought that's what I was saying.
Just to go back, what you were to say, is there any, when it comes to breaking a bone,
Yeah.
I know we moved on, but I just want to, is there anything clear that we know? Is it a type of bruising when it comes to...
So it won't be it will be the deformity that you see.
Yeah.
Yeah. And if it's a really bad break and it's sticking through the skin, then you know it's broken. But if it's just deformed and you think it's broken, it probably is, but you can't guarantee that.
So often we say the more definitive signs for broken bones are if they've got a right angle somewhere they wouldn't have had a right angle before, so an obvious deformity. So if this part of your arm's facing that way, that's never going to be normal, right? If you compare one side to the other, so if you think they've got a break or they've got pain in their right leg, if you compare it to the left, does it look the same? Is it the same length? So when the bones break, particularly your leg bones, arms not so much, but particularly leg bones, particularly thigh bones, because the muscles are really strong. So imagine that if you get a break here and the bones move, the muscles will contract, and so the limb that's broken might be a couple of centimetres shorter than the other one. So that can often tell you as well.
Okay. I remember going to someone who'd broken the shaft of their thigh, and the leg was pointing at an impossible angle towards their shoulder. So you might see it and it might be obvious, but I've been to lots of people who've broken the neck of femur, so they've had a higher up break, and it's not been so obvious. And we classically think of that break as the leg being shorter because it gets pulled up by the muscles and it gets rotated because of the way the muscles are pulling on it, but sometimes it can be quite subtle and it's not so obvious.
How would you convey someone to hospital who's got that right angle sort of thigh bone or something like that?
So you try and put it into place, because
Yeah.
part of putting it into place will also work as painkiller.
Right, okay.
and then you get them to hospital.
Yeah.
Unfortunately, if someone's managed to break their thigh bone like that, it means they've got lots of other things
Yeah.
wrong with them.
Oh, yeah.
So
Yeah.
so it commonly will be an end of life type of injury. So
it could break all the
yeah.
I mean, so for what we call angulated fractures, so bones that have got an angle in them they didn't have before, they will typically, for me, get ketamine at a sedation level, sedate them, then pull it straight,
Yeah.
do whatever you want with them. You've got about 15 minutes to get them packaged. By the time they wake up, they're in the back of an ambulance.
I was a lot nastier. I gave them some morphine. Didn't wait quite long enough, but by the time I'd finished straightening it, the pain had gone.
But most ambulance crews don't carry ketamine. So what they'll carry is morphine. But in London particularly, they'll have help. They can ask for help and they'll get it.
You hope. I didn't. I asked for help.
Yeah. True.
In these extreme injuries, when do they start feeling the pain? Is it after a shock?
When it's broken.
Isn't there shock?
Immediately.
Is there shock?
They'll feel the pain immediately. They might not react to it. They might be stunned for a bit, but the pain will be there right from the beginning. Okay. Any questions about any of that? Let me just pause that there.